Good evening, everyone. My name is Eladio. I am a student of Harvard Principles and Practices of Clinical Research, and today we will analyze together the statistics of an intensive care publication in the New England Journal of Medicine. The Interact 2 trial was conducted in 2013. It compared two strategies for lowering blood pressure in patients with spontaneous cerebral hemorrhage. The upper and lower limits of blood pressure in these patients, then that is with acute intracerebral hemorrhage, are a vital part of the treatment decision-making process. These are severe patients who require continuous monitoring and admission at the intensive care unit. Today we will focus on the primary outcome, but before, in order to understand the main idea of the publication, we will use the PICO framework. So the P stands for population. Who is the population studied? It was included patients who had a spontaneous intracerebral hemorrhage within the previous 6 hours and who had elevated systolic blood pressure. The intervention group received an intensive treatment to lower their blood pressure. The target systolic level for them was below 140 millimeters mercury within 1 hour, compared to the standard treatment, the guideline recommended treatment targeting systolic level of below 180 millimeters of mercury, that is a target more conservative, using agents of the physician's choosing. And the outcome that we will focus today on the primary outcome, that was death for major disability defined by the modified ranking scale at 90 days, right? So before doing any statistics, we need to know our variables. Are they numeric? Are they categorical? Are they continuous or discrete? Are our variables ordinal? In this scale, you realize there is a classification from 0 to 6, where there is this increasing severity and goes from no symptoms to dead. It looks ordinal, but also it is difficult to not think about it as something that could be divided into being not severe or being severe. So for the sake of the clinical relevance, the authors decided to divide this scale in two parts. Either the patient was under severe disability or dead or not. So the scale was categorized for either being 5 or 6 or being 0 to 4. It became a yes or no variable, which is categorical, and that will dictate which statistical tests will be used for the analysis. All right, that's for the primary outcome. Because the authors also state in the publication that while they were doing their work, this scale started to be increasingly being more used in an ordinal fashion, and they did that for the secondary outcomes, as you may see if you wanted to read more the article. Before going deeper into the statistics, let's just take a look at the study design, as it is a randomized clinical trial. However, with the intervention with open assignment and follow-up carried out by staff blinded to the intervention. So it was not completed blinded, it was a blinded endpoint trial, which was the best they could do in this scenario. It was also a huge multi-center study. So let's get started on calculating the sample size with the information they provided to check whether that makes sense or not. Sample size calculation is often a tricky part of a clinical trial protocol design, for you will need some information that did not happen yet. For example, how would be the variance of the sample after you test them or after the intervention? How am I going to know? So sometimes one has to go into the literature and look for similar studies in order to get some information like that. One also needs to know the power of the study and the amount of type 1 error that you will allow. That is often 5%, sometimes 1%, but mostly 5%. So this study reported a power of 90% and an alpha of 5%. So we are talking about a categorical variable, and for this matter there will be used a non-parametric test, in this case chi-square. Chi-square test to test the alteration of proportions. In this case, in order to calculate the sample size, we need the baseline proportion of the control group that is expected. That's some information. That's the example of information they probably got from a pilot study or from similar studies in the literature previously done. Also, in the same fashion, they got the information that we need in a change, a relative expected reduction of 14% of the primary outcome. That makes us understand that the expected proportion for the treatment group is half of that variation, right? If one goes down 7%, it means there is a total relative 14% variation. Also, they considered loss of follow-up of 3% and non-adherence of 10%. So how are we calculating the sample size? So first step, I chose to use Stata program to calculate the sample size. So we used the estimated sample sizes for two proportions tests, chi-squared, and with those information I just mentioned, and we obtained with that information a total number of 2,130 patients. That would be exactly 1,065 patients per group. Now let's adjust that for the expected loss of follow-up and non-adherence. So now I am using other application just for the sake of practice. So let's go to the R Studio, where I assigned a few variables. So I assign initial sample size, loss of follow-up, no adherence, and put everything together in a formula of adjusted sample size, which is the initial sample size divided by 1 minus loss of follow-up times 1 minus no adherence. There is mixing, you could do that separately, which is the same thing. And we printed the result displaying an adjusted sample size of 2,439.86, which is approximately 2,440 patients, considering the loss of follow-up and no adherence. And let's now take a look of how close we got of the estimation they have in the publication. In the paper, for some reason, they estimated a 2,800 sample size, which there is a difference that I'm not sure why, and in reality the actual number enrolled was 2,839. For this matter of practice and for studying purposes, it's fair enough. The result for the primary outcome was non-significant, as we can see from the p-value of 0.06. With that, we conclude that the intensive lowering of blood pressure did not result in significant reduction of the rate of the primary outcome. However, taking a closer look to the secondary outcomes, there will be significant results towards an intensive lowering of blood pressure in the ordinal analysis. That will be it. Thank you very much.